مساء الخير. طبعا. It gives me a great honor and pleasure to co-share this session. دكتور نادي تعرف والدكتور إيهاب داوود. The first speaker will be دكتورة غالية from Oman. She is expert in the field. دكتورة غالية just أهلا بيك.
Hello everybody. مفيش حتى كده. Okay. Hello everybody. I hope it will not be tough after this nice opening. I'm honored to be with you, and we will talk about ventricular arrhythmia in heart failure and what's the different approach, what are the risks, how can we evaluate such patients. So catheter ablation and VT trials showed of course, superiority of VT ablation in such cases with heart failures. You know, the most common is ischemic heart disease with dilated cardiomyopathy, and we have the different trials. The last one was Berlin VT that didn't show superiority in preventive VT ablation, and this have been influencing also our guidelines that came recently in 2022 in ESC. So we will go through the different approach and what's new in the guidelines again. All 5 randomized controlled VT ablation trials have shown, of course, that the ICD interventions, the ICD shocks, the recurrent VT-VF, the hospital readmission and improved quality of life have been less in cases that have undergone VT ablation. Of course, with improvement in quality of life, we are gaining also in each year at least $20,000 from the health burden if we calculate it as a cost effectiveness. Not only this, patients with advanced heart failure who are refractory to ventricular arrhythmia, they deserve special considerations. The risk should be weighed between ablation and the risk of the stability of such patient in any procedure that can reach several hours, and the stability of such patient is a big concern during all these hours, especially if you are going to induce a ventricular arrhythmia, if you receive multiple shocks. All these should be weighed in advance before planning any procedure. What about the patient with electrical storm? That is the most challenging clinical scenario that we may have in patient with heart failure. Of course, now I will show you the approach and what have been changed through years, because before we were going to target most of the time the VT, the clinical VT, but now we are going to study more the substrate that is causing this VT, and this became more stable procedure for electrophysiologists, maybe more boring than inducing VT and interrupting the clinical VT, and but it have a higher safety for the patient. Okay. Epicardial ablation in advanced heart failure also is required. So the capability to go to the epicardial service of the heart is one of the capability that each clinician who is mastering the ventricular arrhythmia should master it. What about the ischemic heart disease with VT storm if it's refractory to antiarrhythmic drug? And we know by default in these cases we have only amiodarone, which usually is effective almost on 40%, but the 20% already from the whole population who's receiving amiodarone have the side effects either acute or delayed. So yes, it has effect, but to certain limits. So maybe as electrophysiologists, you have to take over even if the patient stabilized with amiodarone and he came with VT storm, especially reflected by the devices, to consider already the ablation. And this became already class 1 in the recent guidelines. So see what happened over years. LV mapping in a dog model that have been explored in 1915 by analyzing the different segments, and then the advancement that happened over years and years helped us as electrophysiologists to understand what we are doing and what we are targeting. And now 100 years later, from the beginning, from the first description of these LV abnormal ventricular arrhythmias and the different segments, now we are spending a lot of time in analyzing the substrate more than the VT, clinical VT itself, especially in ischemic cardiomyopathy. And we would like to tell you that ischemic VT now maybe is the least challenging in a ventricular storm than non-ischemic cardiomyopathy. So this advancement make us differ in our approach. So before we were looking to the clinical VT, inducing, going to 8 morphologies, 10 morphologies, to VF, to recurrent shocks. But now we are looking only for what you see here, the late fragmentation, which is present here in this. So we map the substrate in sinus rhythm, and we see this fibrosis that create a delayed electrical signals that are our target usually as electrophysiologists to go and study further and further until we get of course, this also, the mapping of stable VT is a good chance for us because the stability is the main issue for us in cath lab. So we, as we have been educated that we need to identify the entrance and exit, and there are some substrates that are just bystander. We don't need to go over all this, but we want to go to the active channels that are causing the dependency of such ventricular arrhythmia. So again, see these delayed potentials that we have been described. These delayed potentials are the channels that are exiting this type of VT, which is already wide, complex, bizarre, and we have to consider the endocardial substrate studying. This is by our colleague, Dr. Karbushikyu, who differentiated the outcome depending on the clinical baseline, depending on the ejection fraction. So worse ejection fraction is a worse outcome, even and less success. This was in 2008, but this change, and also my thesis in my cardiology MD was regarding the VT storm, and we found that the clinical underlying comorbidities like renal dysfunction and ejection fraction are the most predictor of outcome. But this have been changed over years. Now we are more to the epicardial mapping and understanding the substrate more and more, and spending a lot of time in understanding the substrate until we start to ablate. Also, we have to understand that there are certain complications. One of the worst is pericardial effusion, and this case, you know that little fluid accumulated, even 100 ml, may compromise the patient and the stability of clinical stability during procedure. So what we are doing, we usually we go and analyze the substrate. If it's ischemic, if it's non-ischemic, this is other more challenging clinical condition I will show you. What about the acute hemodynamic decompensation that happens? In fact, we have to balance the time and the procedure and the outcome. And once we have a patient who start to decompensate, it means something. It means that even on the long-term outcome, the patient will have higher mortality. So even the instability of the patient during a procedure is already an index of lower outcome. So what in coronary artery disease, as we said, preventive ablation has no superiority. So we are just exposing the patient to a procedure which is complex with no benefit in this case. Catheter ablation should be considered in a VT which is hemodynamically tolerated. Also, it should be class 1 indication indicated when we have a VT storm. As we said, quality of life, of course, ICD shock is already with a compromised quality of life, including from depression, from even to suicide sometimes. Thinking that we were facing the Western country until we reach sometimes to turn off such devices. So it's a real complex situation that we face. Okay, what about the amiodarone? See the amiodarone, and it doesn't show superiority in relation to the ablation. So ablation should be considered, and if you don't have it in your center, you have to refer it to a center who is doing these type of cases. This is, as I told you, the cost of life. Okay. How can we evaluate, is this patient having a higher risk, yes or no? There are multiple risk stratification in these cases. One of them is the clinical background, like NIHA class, if the patient has a CRTD, if he needs hemodynamic support. And we have, I will go to the PINEST score that is the most reliable and specific and sensitive for outcome. We calculate this type of score, which have a pulmonary, if the patient have COPD or the age, general anesthesia is required, the ischemic cardiomyopathy as background, and NIHA. If a patient has more than 15%, we identify him as high risk. So what does it mean? Identification of high risk, it means the planning of the procedure. It means that we need more support. We may need even ECMO in such cases. We may need even an expert team as persons and nurses, and we usually fix the teams in these cases that they know what we need. The most important factor for us is the anesthetist, of course. Okay, about the equipment, about the imaging that we need in advance, it's something that we have to plan at 360%. We have to know that we are going maybe to the LV if we have a VT originating from the left ventricle, or the RV if we are dealing with arrhythmogenic dysplasia, or both ventricles, or epicardial. Does he have an LV thrombus, yes or no? Does he has an ejection fraction, low blood pressure, a low ejection fraction? All these should be planned. If we can do an MRI, if the ICD is not already in, that is also an other imaging tool that we merge with our procedures. So we plan also the access. Do we need to go venous, retrograde aortic approach? Both approach that is more frequent in the complicated procedure. If we are going to the epicardial puncture, so we need to do it from the beginning, not in the middle of the case. For example, this is a case of VT storm. This is a patient who's not responding to amiodarone, coming with recurrent VTs, and see what we are going. This is unfortunately was induced without data, but what we see, this is the color code of such map of ischemic myopathy. So see how much he's diseased and how much he is suffering. So I will go ahead with different clinical scenario. This is, as we said, we go and map until we find the scar, and we stop there until we identify the VT that is causing his arrhythmia, and we start to identify the channels and do ablation until we interrupt the VT, and we reinduce. Usually I consider the theme of Professor Paolo Della Bella, that he do a lot of aggressive induction until the end, until we are sure that we don't have any type of VT inducible. I will show you different approach. For example, this is a lady with low ejection fraction that had a VF all the time. Although the amiodarone, she was not stabilized, she didn't have a prolongation of QT, because sometimes the amiodarone by itself may destabilize such patients. But in this case, we took her to the lab, we did coronary angio, of course, and we did ECG, which is the most important to know what we are facing. Do we have identified trigger? In this case, yes or no. We did for her in the same timing, in the same setting, coronary angiography to see if this case is have an ischemic insult, yes or no. And we did two map until we found papillary muscle, which is the most common in Purkinje inflamed myocardial VF. Okay. What about epicardial ablation? Yes, should be considered in non-ischemic cardiomyopathy. Maybe in 50% of our cases, we have to consider epicardial. See what we are talking about, the epicardial substrate that need to have approach epicardially to study them. Well, sometimes we don't find anything endocardially.
دكتورة غالية فندم، ممكن for the time أنا منير. Just for the time, for the sake of time, just you can.
In the end, 3 minutes. Okay, or 2 minutes even. Okay, so this is another thing that we have to consider in epicardial approach. We have the liver, and we showed you some figures of a liver that have been injured already, or even the stomach, sometimes the lung. So we have to have all this in mind. We go like at epicardial effusion, but in dry situation by our needle until we pass, and we go with the wire, and we ensure that is surrounding the heart, that is in the pericardium. Of course, we are always happy when we have a clear fluid, not hematic. Sometimes you find adhesions like this, especially if the case had some sort of myocarditis. So what about idiopathic VF? What's new? The genetic counseling is important in these cases. What's new? That the autopsy post arrest or post mortem now is highly indicated. This is a case, for example, it's just to show you what clinical scenarios that we may face. This is one case just done a few days ago or 2 days ago. He's a young patient who is 43 years old with recurrent ventricular arrhythmia, although he's fully loaded with amiodarone, and he had this ventricular arrhythmia. What we go to do usually, we like to study the beginning of this ventricular. Do we have a PVC that have certain coupling? Do we have any clue what we will face? This patient who had a CRT. Unfortunately, we didn't have a real clue. It was just a VF runs. But what we did, we went inside and we were planned with an ICE intraoperative. I'll show you now. This is his ICE. See, what do you observe? I need somebody to comment on this. This is the LV and that is the RV. ما فيش وقت خلاص. You see non-compaction like, yeah? In fact, I will tell you the end of the story. This is what we induced in the cath lab, not by intention. It happened during manipulation, and he goes to blood pressure 0. This is a terrifying situation. Again, we went from the beginning to epicardial because it's non-ischemic cardiomyopathy, and we considered the epicardial axis. This what we found. We found a voltage map that is clean inside, but what is scaring that all epicardial is almost a gray. But when we went to the pericardium, he had also normal voltage, so he had severe intramyocardial fibrosis.
دكتورة غالية معلش
and we
it's
are done.
very interesting صحيح. Thank you very much. Thank you. Thank you.
You're welcome.
So, Professor Ghalia, thank you very much. It was an excellent talk. Would you send a message here? The room is filled with mostly cardiologists that are not electrophysiologists.
Yeah.
So we face many types of infarctions. The site of the infarction, would you want to comment on the late ventricular potentials that are the substrate of ventricular tachycardia and ventricular fibrillation? In which site is it more common? So then we send a message for the cardiologists that these patients are more vulnerable for VTs and VF.
A very nice question. You know, the completed infarction usually come less challenging than those who had a mixed substrate between acute and subacute ischemia that have been resolved maybe later. Those are a bit tough. But if we have an aneurysm, of course, the margin of the aneurysm is usually which we target, especially if we have LAD region, and if we have a posterior infarction, this could extend even to epicardial substrate and should be considered because there is an associated inflammation that happens with the posterior infarctions. So it depends on, of course, once we have a better LV function, this is for us a better room to stabilize, to have the patient stable, to study well, to induce without having fear of the patient crush. If we have a septal substrate, this is the worst because usually it comes like ping pong on the septal side, even between the right and left side. And so there are different, but usually if we have aneurysm, we go around the margin. If we have acute ischemia with VF that doesn't respond, that continue to have a VF, we had 2 cases that we took to the lab. We stabilized the ablation around the margin of the recent MI, and the patient stabilized very well and he survived.
Thank you. Thank you very much, Dr. Ali.
Thank you, Professor Ghalia. Now, for the sake of time, we're going to proceed to the next presentation. It's about the most important topic in the advanced heart failure treatments, about the LVADs. We'll see about how is NovaCore, Jarvik, the thoracic group of heartmates, the hardware, and how they would affect the longevity and help patients with heart failure. See, Professor Carol Shaker, we're going to listen to certain, probably very nice topic.
Thanks to the panel. I'd like to thank Professor Magdi Abdelhamid and the Egyptian Working Group for this kind invitation. I'll speak about left ventricular assist device. This is my agenda. Current state of LVAD with emerging role and many challenges. The size of the problem. Heart failure has been defined as a global pandemic in 2017 with more than 26 million patients with heart failure. More than up to 10% of this patient has advanced heart failure, with increasing mortality that reach to 30% in first year and 50% in the 3 years mortality. Despite being the gold standard of treatment is heart transplantation, it's still limited with restricted supply of donors, and worldwide less than 6,000 patients have the transplant, including adult and pediatrics. Historical background of LVAD. In 1966, Dr. DeBakey and colleagues implanted the first LVAD in patients with severely impaired ventricle post-operative for aortic and mitral valve replacement, and this LVAD remained for 10 days and removed after full recovery. After that, the LVAD passed in different stages from first, second, and third generations. The first generation was pulsatile flow, but it was large device, noisy, with short durability. Next duration is second and third generation is continuous flow with much advantage over the first generation. The more popular second generation is HeartMate 2, and third generation is HeartMate 3 and HeartWare. This is component of LVAD. We can see this is the pump implanted in the left ventricular apex, receives the blood from the left ventricle and pump the blood through the outflow graft to aorta. The pump is connected with percutaneous cable, which named the drive line, that connected to controller outside the patient and connected to the rechargeable batteries. This is the most recent device available in markets, HeartMate 3. Notably, we have implanted all these recent devices in Egypt, HeartWare, HeartMate 2, and HeartMate 3. Some principle, RPM is the revolution per minute. It equals the speed of pump, which should be adjusted according to the left ventricle of the patient and size of the patient. Flow is the device output produced by the LVAD, should be between 4 to 10 liters per minute. And it decreases if there is some problem in LVAD, like thrombus in any part of the device, hypovolemia, arrhythmia, or any causes of tachycardia. The watts is power consumption by the device, which increase by thrombosis of the LVAD. Evidence-based. The roadmap trial is landmark trial that compared between two groups of advanced heart failure patient with LVAD and optimal medical treatment that showed better survival and functional capacity in patients with LVAD over optimal medical treatment. Based on all heart failure guidelines, durable mechanical support LVAD is indicated in patients with severely impaired ventricle ejection fraction less than 25%, dependent patient on inotropes, or very symptomatic patient with NYHA class 3 to 4 on optimal medical treatment, frequent hospitalization, and low cardiopulmonary exercise, low VO2 max less than 14 milliliter, and end organ dysfunction attributable to low cardiac output. And according to ACC heart failure guidelines, mechanical circulatory support LVAD is class 1 indication in patients with advanced heart failure on inotropes, and the class 2A should be considered for patients with symptomatic heart failure without inotropes, as it improves functional capacity, improves quality of life, and survival in this vulnerable group of patients. Intermax classification. Intermax is an initiative registry for mechanical circulatory support that initiated in 2005, has clustered the patient with advanced heart failure to 7 groups. The group number 7 is less sick patients, while group 1 is more sick with critical crashed cardiogenic shock that may necessitate mechanical circulatory support. And in most patients with LVAD, they were in class from 1 to 4 with poor outcomes in Intermax class 1. Timing of LVAD, it's very critical that LVAD shouldn't be too early and not too late. Not too early because it's a burden on patient, family, and the cost device shouldn't be put for any mild symptomatic heart failure patient, and not too late to avoid irreversible end organ damage. LVAD may be bridge to transplantation, bridge to candidacy for patient with reversible contraindication to transplant, bridge to recovery, or destination therapy. It's a multidisciplinary team, include heart failure specialist, cardiac surgeon, and other team. Contraindication, LVAD contraindicated in active systemic infection, infective endocarditis, active substance abuse, as this type of patient will not be amenable to taking care of device or taking care of medication, severe coagulation or metabolic disorder, as the device necessitate oral anticoagulation and antiplatelet, irreversible organ damage, or poor neurological cognitive condition. Some relative contraindication include mechanical aortic valve. This is an example for patient from our patient with mechanical aortic valve with severely impaired ventricle. For that patient, we had aortic valve replacement with bioprosthesis and LVAD implantation, and he is doing well till now, 7 years post-LVAD. LVAD, LV apical thrombus is relative contraindication of if it's small like this, can be removed during the surgery, but if it's large, it's difficult and risky for the surgery. Intra-atrial shunt should be corrected to avoid any reversal shunt after LVAD. The outcomes. For the most recent Intermax 2020 annual report, it showed improvement of survival in LVAD patients over 5 years. This report included more than 25,000 patients with LVAD, but it still has multiple complications and adverse events like device malfunction, driveline controller damage, pump thrombosis, cerebrovascular stroke, infection, sepsis, or infective endocarditis, bleeding, cardiac arrhythmia, and rehospitalization. This is an example of device malfunction. This is example for RV failure post-LVAD, which is a major complication, or driveline infection or driveline problem. And regarding the brightening field in the LVAD, recovery is well established in some patients who recover LV native contractility in about 5 to 10% of patients with LVAD after unloading and pharmacological treatment. These changes occur on molecular, cellular, tissue levels with improving of fibrosis biomarkers and apoptosis, also other biomarkers. Restage heart failure trial. This study was initiative, but it showed some hope as up to 50% of patients recruited had recovery with prolonged over 3 years, but it was limited with number of patients, was only 40 patients. This is an example of one of our patients in Aswan. This patient suffered from advanced heart failure, recurrent hospitalization, severely impaired ventricle, you can imagine, severe mitral regurg, that was improved significantly after 1 year of support with pharmacological treatment, and this patient has till now 4 years without support. Another example, recovery may happen also for non-compaction. This patient with severe impaired ventricle ejection fraction may be less than 10, severe mitral regurg. That showed marked improvement after LV unloading. Looking to the future, firstly, European Association of Cardiothoracic Surgery reported that all patients with non-ischemic dilated cardiomyopathy should be for recovery with LVAD, and another developing system with transcutaneous energy transfer for wireless, afford a wireless LVAD to avoid the complication of driveline and driveline infection. To be concluded, increasing the prevalence of advanced heart failure and unmet need for transplant, the LVAD gained a vital role LVAD improves quality of life, patient symptoms, and survive. Being has many challenges and risks. LVAD need multidisciplinary, meticulous management. Recovery is long journey, but it deserves every effort. Future still carries hope for more development of LVAD. Thank you and have a nice stay in Aswan.
Thank you very much, Dr. Kirolos Shaker. Very nice. I'd like to ask how many apparatuses you implant per year, and the cost, I know, 1 million or more Egyptian pounds.
Firstly, till now, we started the LVAD program since 2014, and now we have 67 patients, and we are following 3 Egyptian patients had LVAD outside of Egypt, and now they are staying in Egypt. And the cost, regarding the cost, it's about 95,000 American dollars.
Thank you. We have a question, please, for us.
Excellent presentation. Thank you
Thank
very
you.
much. I have a question regarding the only center in Egypt now that places the assist devices. And congratulations on such a great achievement, of course, for the country. What do you do with the patients who are getting this at a young age, who are supposed to get it as a bridge to transplant? And the follow-up question is, what is the limitation to now have a transplant program in Egypt, do you think?
Thank you for your excellent question. First question, unfortunately, we don't have heart transplant in Egypt, so our main goal to either bridge to recovery or bridge to transplant outside of Egypt. But it's very limited due to it's very costly and restricted donors. The excuse me, the second question about
is what's the limitation? And even from a cost standpoint, I know organ donation is the issue and the laws for organ donation, but I'm sure that having a law for organ donation is not difficult in Egypt. And ultimately, if people accept the idea, then you'll save a lot of patients by either going to transplant directly or bridging them from the LVAD to transplant at a cost that is a lot less than these devices. Because if you put the device in somebody who is 30 years old, this patient is not destined to live forever with this device at the end.
Yes, I agree with you, sir. Regarding the heart transplant in Egypt, we hope, and I think there is some steps in this program. We all hope that in Egypt. Yes.
Thank you very much, Dr. Kirolos. As regard your thank you for very nice updated lecture as regard the LVAD. I think the outcome improved the last 10 years as regard the newest one, HeartMath 3.
Yes.
What your opinion? It is your prefer if the patient, as there is 2 options, can do LVAD bridging for transplantation better, or you put in LVAD only, especially the follow-up. It is very need meticulous follow-up in LVAD, especially there is predictors of dysfunction or for LVAD sometime not all know. Second question, if you do transplantation, I think the beneficial, it is better than LVAD. What your opinion?
Thank you, Professor, for this very good question. In my opinion, heart transplantation is still the gold standard for management after excluding any reversible cause of the cardiac condition for this patient. So if heart transplantation is available, this is the gold standard.
Professor Hani?
Yes, please. Technically speaking, you are putting this machine, HeartMath 3, we know, and it must be synchronized with the left ventricle contraction, or just you don't depend at all on the 2 together, because it's very important for unloading and for atrial fibrillation, and most of the patients have atrial fibrillation. A lot of patients. What do you do?
It's very good technical questions. The LVAD should proper unloading the left ventricle to allow the left ventricle to unload. So we adjust the RPM, the speed of the device, depending on the size of left ventricle, the size of patient, and the volume status of the patient. So we adjust the RPM, and after this adjustment, we assess the left ventricular dimensions to make sure that the left ventricle is smaller to allow the unloading with allowing some space to the left ventricle to contract to keep the aortic valve open. It's a very crucial point because if the LVAD speed was very high, the aorta will close and will not open again and become sclerotic. This will make the patient very dependent on LVAD only.
Okay.
Thank you.
Just to make a little comment, the price is almost 90, as you've said. The total artificial heart, which is next to the LVADs, we have 3 total artificial hearts in the world. The Abiomed now is discontinued. The Syncardia CardioWest costs around $130,000. And the heart, the last one is the Carmat, which is a failure at this moment, of course. Then the heart transplantation, the cardiac transplantation, it costs almost $1.2 million US at the current stage. So I don't think there will be a space now for heart transplantation, especially in Egypt. Another point worth mentioning is that the HeartMate 2-year longevity is 76%. It's almost near to the artificial heart transplantation, which is 82%. That's a good point. Thank you very much for your talk.
Thank you.
Thank you very much. We have to proceed to the next speaker, Professor EGYHF from Sweden. He will speak about baroreflex activation therapy. Dr. Saviras.
Thank you so much. I always have some issues with this thing. Thank you so much for, again, the kind invitation to be here today with you. This is still the same. So, well, when we consider autonomic modulation in heart failure, there have been several attempts. So there has been spinal cord stimulation has been tested, the rectal vagal stimulation has been tested, and carotid baroreflex activation therapy, which is the topic of today, has been tested. Unfortunately, the first 2 methods have been unsuccessful, but for carotid baroreflex activation therapy, there are at the moment good data, which we might discuss together today. So first of all, why carotid baroreflex activation therapy? By stimulating the carotid sinus, it's possible to increase vagal activation. This actually leads to several effects which might be beneficial in patients with heart failure. So you might have vasodilatation, you might have a reduction of the stiffness, you might have a reduction on heart rate, reduction of myocardial work, increase in diuresis, natriuresis, and a decrease in RAS activation. So all these different consequences of triggering vagal activation actually are all beneficial in patients with heart failure. Therefore, there have been several trials which have been testing this method in patients with heart failure. This is the phase 2 trial, which was conducted on baroreflex activation therapy. It's called the HOPE4 heart failure trial. It was a small trial, 76 patients assigned to the treatment arm versus 70 to the control arm. And inclusion criteria were aiming to select a quite sick population of patients with heart failure. So NIA class 3, an ejection fraction equal or lower than 35. These were patients optimized with guideline-directed medical therapy. So they had to take RASI, beta blocker, and diuretics at that time. This was done a few years ago, so there was no SGLT2 inhibitor, for example. The heart rate must be between 60 and 30. There should not have been any hypotension and an EGFR over 30 with a 6-minute walk-in performance between 150 and 450. So you see, this is the patient population, and what is quite interesting to see is the very high use of medical treatments in these patients were very well optimized and quite young population, but this is usually seen in trials in device, in heart failure, and nothing extremely relevant to report in terms of baseline characteristics. The primary outcome of the trial, so the efficacy endpoint, was a change in anemia class at 6 months follow-up after implantation, and also improvement in quality of life and 6-minute walking distance. And actually, the treatment, as compared with the control, reported an improvement of all these 3 outcomes. As secondary outcomes, also NT-proBNP was measured, and NT-proBNP increased much more in the control arm compared with the treatment arm, which of course here leads us to reflect regarding the progression of heart failure. And also some other outcomes which were tested, they're here on the right. So number of heart failure hospitalization per year, and heart failure hospitalization days, and actually the treatment reduced all these secondary outcomes as well. Important in device trials is always also to assess safety, and the treatment was safe. The primary safety outcome was a system and procedure-related major adverse neurological and cardiovascular events, and it was only 3%. The phase 3 trial, which followed the previous one, was actually the HFrEF. It was a trial which tended to enroll a quite similar population compared to the previous one, but there was also NIA class 2 was considered as well. A 6-minute walk distance was similar to the previous trial, so between 150 and 400. Here there was also a inclusion criteria in terms of NT-proBNP levels. Once again, patients had to be on stable medical therapy, optimal medical therapy, and patients should not have an indication for CRT or upcoming indication for implantation for CRT. So again, we have around 270 patients in this trial. Optimal therapies here are reported for treatment and control. Around 30% of patients were receiving ARNI, which is quite good proportion in these patients. High use of RASI as well, very high use of beta blockers as well. The very high use of diuretics is clearly indicating that this was a very sick population, and also a higher use of mineralocorticoid receptor antagonists compared to what we see in real world life. So here we had around 50%. In real world life, we usually see quite less. So quite selected population as well. And let's see the outcome analysis here. So in the HFrEF, primary outcome was again quality of life, and quality of life was improved by 14 points when it comes to the Minnesota questionnaire. And when we consider quality of life as an outcome, we also consider as a significant change at least 5 points. Although this is a little bit arbitrary, there are no clear data showing that this is what it should be, but this is what we do. In terms of 6-minute walk and test, there was also like a huge effect. So 60 meters more in the treatment versus the control arm. And also in terms of NIA class, 34%, that was 34% of patients improving at least one NIA class. And very extraordinary that the safety events had exactly the same frequency as compared with the previous trial. So only 3% of patients reported an advanced neurological or cardiovascular system or procedure related event. So very safe. So this is a summary of what it has been done in this specific field at the moment. Good results in phase 1 with the BAT in HF trial, where the mechanism of action of this therapy was understood. That's why the following phase 2 trial was conducted, and following that, the device got a CE mark approval. And then that's why the phase 3 trial was conducted later. And after that, after having observed that the treatment was effective in terms of quality of life, 6-minute walk test, and so on, it was the drug got the device got approval by the FDA in the United States. This data have been summarized in this very interesting meta-analysis, where actually it is shown that the effect on all the outcomes, so 6-minute walk test, NIA class, quality of life, and NT-proBNP levels was consistent across the different trials, so no heterogeneity, and even across several subgroups which are reported here, so different NT-proBNP levels having or not a CRT. And this was the case for all the outcomes reported here. So in the FDA approval in 2019, the indication for this device is for patients who are symptomatic despite GTMT, which a little bit highlight also what it was considering the trial as inclusion and exclusion criteria. So NIA class 2, 3 and LVF less or equal to 35, NT-proBNP lower than 1,600, no CRT. These were actually the selection criteria of the phase 3 trial, which was conducted. And again, it was highlighted in the approval that the treatment, so the device is aiming to improve quality of life, 6-minute walk distance, and functional status of patients. So when considering this, this type of therapy, it's important to characterize adequately population in terms of etiology, NIA class, LVF, QRS morphology and duration to understand whether there is an indication for CRT as well, and NT-proBNP levels. Potential contraindications like bilateral carotid bifurcation above the level of the mandible, because there might be a problem with the procedure. Baroreflex failure or autonomic neuropathy, uncontrolled symptomatic bradycardia, more than 40% carotid stenosis, and ulcerative plaques in the carotid artery. And that there might be some possible limitations which depends on the healthcare system, the patient's choice, and the availability of the device. So these are the indication and the perspectives. At the moment in US, this therapy is indicated for the improvement of symptoms and quality of life and functional status, as I was reporting earlier, in patients who are similar to those enrolled in the phase 3 trial. So NIA class 2-3, an ejection fraction which is reduced, low NT-proBNP levels, and this is reported beyond the approval by the FDA also in the current guidelines. In Europe, there is no discussion regarding, no indication regarding this device in the new guidelines, in the 2021 ESC heart failure guidelines. And the reason is that there is no data on mortality, morbidity. And as we know, ESC guidelines are very much more conservative than American ones, and evidence is graded in a different way. So in Europe, there is much more weight for mortality and morbidity, whereas in US, it's even more considered quality of life and functional capacity. What is coming next is the HFrEF trial. And in this trial, the primary endpoint will be a 6-month change in left ventricular and systolic volume index. And a secondary outcome, they will test changes over time in ejection fraction, which kind of brings us closer to testing hard outcomes. And that's it from my side. Thank you very much for your attention.
Thank you very much, Professor Tavares.
There is one small question.
For the sake of time, بس اتفضل.
There is a pacemaker that stimulates the left ventricle during the QRS, gives the impulse during the QRS, and it improves the quality of the ejection fraction. Is the results the same? Are the results the same this baroreflex as the pacemaker?
There are at the moment no studies on progression in terms of ejection fraction with this procedure, but they will follow in this BIRD HF trial, which will kind of bring us closer to mortality and morbidity, because we know very well that changes in ejection fraction are linked to heart outcomes.
Thanks, Dr. Savaraz.
Thank you.
Now we are proceeding to the next speaker, Dr. Tariq Abdelhamid. He will speak about when to correct secondary mitral regurgitation and how.
Thank you. I'd like to thank the organizing committee, Dr. Magdi Abdelhamid, for inviting me. I hope I will not take long in this presentation. Secondary mitral regurgitation, when and how to correct. We all know that moderate or severe secondary or functional mitral regurgitation accompanies heart failure in about 1/3 of patients, and it contributes to the clinical deterioration, the progression of the syndrome, and adverse outcomes. And the management necessitates a timely referral and a multidisciplinary heart team. Optimization of pharmacological and device therapy according to guidelines is crucial. The vicious cycle of myocardial injury that leads to left ventricular remodeling, and that in turn leads to mitral apparatus changes with annular dilatation and papillary muscle displacement, which begets secondary mitral regurgitation. And this cycle has to be broken at some point, and this is the importance of targeting functional mitral regurgitation in the management of heart failure. This curve shows that patients having severe functional mitral regurgitation have a worse survival over the years, and this is in case they have ischemic or non-ischemic cardiomyopathy. In this study of 163 patients, a retrospective analysis over 6 years, it was found that patients having sustained severe mitral regurgitation, or those having worsening of the mitral regurgitation, have worse MACE, as well as higher incidence of all-cause death over the long-term follow-up. And this has shown that medically managed patients could be successfully treated, and it helps to decrease mitral regurgitation almost 40% of the patients. The therapeutic options for functional mitral regurgitation includes guideline-directed medical therapy, cardiac resynchronization therapy, surgical mitral valve repair, the surgical mitral valve replacement, transcatheter mitral valve repair, as well as the early first-in-man trials of transcatheter mitral valve replacements. The heart team approach is very crucial in the context of management of functional mitral regurg. It is composed of a multidisciplinary, collaborative group of physicians and caregivers that take rigorous approach for patient care to maximize the outcomes. And multidisciplinary approach for the management of secondary mitral regurgitation is important, taking in consideration the stepwise approach from guideline-directed medical therapy to CRT to surgery, as well as transcatheter interventions. Going through the pharmacological approach for management of functional mitral regurgitation, it dates since the early 90s, where captopril has been found to effectively reduce functional mitral regurgitation, especially at the higher doses. Also, the efficacy and safety of supramaximal titrated inhibition of RAS system using higher doses of benazepril and valsartan has shown also to reduce the end diastolic volumes, mitral regurgitation, and wall motion score index. Reversed remodeling and the effect of metoprolol as well as carvedilol in reducing the burden of functional mitral regurgitation has also been evidenced in clinical trials. Regarding ARNI and the angiotensin receptor neprilysin inhibitor in functional mitral regurg, the PRIME study showed that in 118 patients, the use of sacubitril valsartan compared to valsartan alone showed that it had better improvement of the patient's symptoms, as well as the accomplishment of the primary endpoint, which is a change in the effective regurgitant orifice area significantly using sacubitril valsartan. Accordingly, a guideline-directed medical therapy titration conveys a threefold increased chance of reducing functional mitral regurg severity. And this portends for combined beta blockers and RAS inhibitors, combined beta blockers and MRAs, combined RAS inhibitors, MRAs, the combination of RAS inhibitors, beta blockers, mineralocorticoid receptor antagonists, as well as ARNI standing alone, also has been found to significantly reduce secondary mitral regurgitation, especially with the adequate titration of the doses. Regarding the SGLT2 inhibitors, especially empagliflozin, it has been found to have a good influence on reverse remodeling of the heart. It targets the LV systolic function, reduction of the LV mass, the LV volumes, and also improvement of the systolic and diastolic function. And this has been also found to benefit more with patients having heart failure with reduced ejection fraction. In the empatropism trial in non-diabetic patients with heart failure and reduced ejection fraction, it was found that using empagliflozin as compared to placebo showed a reduction, a significant reduction in end diastolic volumes, end systolic volume, the LV mass, as well as improvement in the left ventricular ejection fraction. The transcatheter devices used for repairing the mitral valve has different mechanisms, either edge-to-edge repair, including the MitraClip and the Pascal, chordal repair, the indirect annuloplasty, or direct annuloplasty. The most mature of which, and that has gone through many trials, is the edge-to-edge repair. We all know the COAPT trial with its positive outcome, showing that MitraClip plus guideline-directed medical therapy showed significantly less death and heart failure hospitalization as compared to guideline-directed medical therapy alone. This conflicts with the MITRA-FR trial that showed no significant difference between both. And we all know that the possible reasons for this conflict is probably because of the different clinical and echocardiographic inclusion criteria encountered in both studies. The key echocardiographic criteria for functional mitral regurg includes those related to the mitral valve, like the tenting area and the coaptation depth, as well as those related to the left ventricle, like the LV diameters and the sphericity index. This brings us to a recent study that targets what is called the COAPT-like profile and how it impacts the outcome of functional mitral regurgitation. It implies that all of the following three criteria should be fulfilled to define COAPT-like profile. The first is the absence of severe left ventricular impairment with a left ventricular ejection fraction more than 20% and an end diastolic diameter that is less than or equal to 70 millimeters. Absence of right ventricular impairment or severe pulmonary hypertension, as well as absence of hemodynamic instability. The lack of at least one of these three criteria defines a non-COAPT-like profile. Looking to the survival analysis of those two cohorts, we can see that patients who have a COAPT-like criteria had a better freedom from all-cause death as well as freedom from cardiovascular death or heart failure hospitalization compared to the non-COAPT-like profile. Accordingly, a COAPT risk score has been recently proposed. This score has some clinical as well as echocardiographic criteria with a score ranging from -3 to +15. And we can see that the 2 years death or heart failure hospitalization rises the higher the score is. What is intriguing actually is that the mitral clip therapy has the highest impact in lowering the score with -3 points. And what is also more exciting is that the right ventricular systolic pressure, a high right ventricular systolic pressure and RV dysfunction has a higher impact than a low left ventricular ejection fraction. And then this was regarding the mitral clip. Then came the Pascal to add to the important TER criteria for managing functional the interventional management of functional mitral regurg. What is peculiar about the Pascal is that the clasps allow for independent leaflet capture and the ability to fine-tune the leaflet position. Lately, the CLASP 2D trial has been announced in the late TCT conference, showing that the Pascal system was non-inferior to the mitral clip system, and we are awaiting the results of the CLASP-2F, which targets precisely the functional mitral regurg patients in a one-to-one randomization fashion. The CLASP-2D randomized trial showed that at 1 month, which was the primary endpoint, the freedom from MACE was not significantly different between Pascal and mitral clip. We can see that the curves are still diverging at 6 months, but still did not carry any significant difference. Also, the mitral regurg reduction was quite similar at 6 months between both devices. This is why the Pascal gained the FDA approval for degenerative mitral regurg lately in the news release. So we can see that the hype cycle of functional mitral regurg starts from an innovation trigger, and then the peak inflated expectation with the EVEREST-2 trial. The MITRA-FR brought us to the trough of disillusionment, and then a slope of enlightenment with the COAPT trial, rising up to the plateau of productivity with the upcoming ReShape heart failure, Evolve heart failure, and Matterhorn studies. Of course, the transcatheter mitral valve replacement devices, a lot of devices in the market are nowadays undergoing first-in-man trials. Most of them are from Edwards, also a couple of devices from Abbott. According to the ACCHA guidelines in valvular heart disease, they emphasize that the standard guideline-directed medical therapy is the mainstay in the management of patients with functional functional mitral regurgitation. And it also emphasizes about the importance of an expert cardiology to implement the monitoring of this optimal guideline-directed medical therapy. Finally, regarding the treatment approach for secondary mitral regurgitation, first we should start by guideline-directed medical therapy, which is governed by an expert heart failure specialist along with CRT. And then if patients are undergoing CABG due to multivessel disease, then this patient should undergo mitral valve surgery as a class 2A indication. If the patient has severe stage D mitral regurgitation and the ejection fraction is more than or equal to 50% with severe persistent symptoms despite guideline-directed medical therapy, then surgery should stand as a class 2B indication, while if the ejection fraction is less than 50% with persistent symptoms, then we should assess the mitral anatomy. If it's favorable, then transcatheter edge-to-edge repair is preferred with a class 2A indication. Otherwise, severe symptoms with non-favorable anatomy for mitral valve repair, then mitral valve surgery should be adopted as a class 2B indication. Finally, the take-home messages. Patients with symptomatic heart failure and moderate or severe secondary mitral regurgitation should be referred in a timely manner to a multidisciplinary heart team. The heart team should first evaluate and optimize the guideline-directed medical therapy and then consider the respective roles of device therapy, transcatheter mitral interventions, and surgery with the order of implementation. The diverging results of the MITRA-FR and the COAPT place even greater emphasis on the need for careful selection of patients for transcatheter repair techniques and identifying and improved imaging parameters that will predict positive clinical outcomes. Thank you.
Thank you, Dr. Tariq, for your excellent lectures, and for the sake of time, no questions. And thank you, shukran.